spring ligament tear, also called the medial calcaneonavicular ligament. Most commonly occurs through an indirect injury mechanism. So it's following chronic tibialis posterior tendon disease, where failure of the tibialis posterior tendon subsequently results in a biomechanical overload of the spring ligament complex, and then that tears subsequently. Direct injury is less common. It was described by Hinterman in 2003. It can occur following a heavy fall on the feet or following an unaccustomed increase in impact level of activity, usually a pronation force causing the spring ligament to tear. On exam, you would see you would be able to palpate a tender medial plantar foot. Single leg heel raising corrects the hindfoot valgus pronated deformity, which would indicate that the patient has a purely spring ligament injury with sparing of the tibialis posterior tendon. So differential diagnosis would include deltoid ligament tear or tibialis posterior tendon tear. Investigations include X-ray of the AP lateral oblique views, and some have suggested a Kobe view for hindfoot alignment to look for deformity, subtle avulsion injuries, and early degenerative changes. In the chronic situation, especially in relation to tibialis posterior dysfunction, this may show changes commonly associated with tibialis posterior dysfunction, like midfoot sag, hindfoot valgus, and midfoot abduction. MSK ultrasound and cross-sectional imaging may be helpful to further document this diagnosis. Treatment in the acute partial tear involves non-weight-bearing cast immobilization for 6 weeks and then return to play based on restoration of biomechanics and strength, along with custom orthotic support. A surgical reconstruction is necessary in the context of an acute complete rupture or a chronic tear with progressive deformity. Post-traumatic synovitis occurs with any ankle injury, and it's due to the presence of blood within the joint causing a reactive synovitis or inflammation of the ankle joint lining. It persists if excessive early weight bearing occurs, typically when the patient is eager to return to training or sport too soon with inadequate rehabilitation. It's provoked by the chronic mild instability around the ankle because of accessory ankle joint movement during activity. It's typically a clinical diagnosis, and imaging would be used to rule out differential diagnoses such as pigmented villonodular synovitis, or more concerning would be synovial sarcoma or some other kind of malignancy, as opposed to PVNS, which is the pigmented villonodular synovitis, the benign proliferation of synovial tissue. Typically it's mono or oligo-articular, but it can occur in the ankle. Crystalline arthropathy like pseudo-gout or gout, and chronic regional pain syndrome. Treatments for synovitis would include anti-inflammatories, relative rest, and therapeutic ultrasound. Corticosteroid injection may be warranted and should follow with limited weight bearing and a gradual return to play. Very seldom arthroscopy with synovectomy is indicated, and if it's related to chronic ankle instability, taping or bracing temporarily for activities of daily living and for sport would help. Some benefit from ankle ligament reconstruction surgery may be necessary as well in recalcitrant or non-resolving cases. Medial tibial traction syndrome is a rare cause of ankle pain. It typically is pain in the medial shin, distinct from the ankle, but it is potentially in the differential diagnosis, particularly when it's down in the distal third of the medial tibia. This is otherwise known as medial tibial stress syndrome, MTSS, but perhaps it's better described as medial tibial traction stress syndrome, in which the thought is the pain arises from the medial shin muscles pulling along the periosteum and causing inflammation of the periosteum, also known as periostitis. It is typically pain from the tibialis posterior, flexor digitorum longus, and the deep calf muscle, the medial soleus. The mechanism of injury is thought to be that, in particular, the medial soleus, as the stronger plantar flexor and inverter of the foot, eccentrically contracts to resist pronation. And so with overuse, repetitive impact, pes planus, excessive pronation results in chronic traction of that medial soleus's insertion onto the periosteum on the posterior-medial tibial border. Other mechanisms include metabolic bone health deficiency. This is often more common in female athletes. Also associated with medial tibial stress syndrome is increased range of motion of the hip in both external and internal rotation, and a lower lean calf girth. Investigations include, in the right context, an X-ray to rule out a full fracture, and also you may see the periosteal reaction. A bone scan would show diffuse areas of patchy increased uptake along the area of concern. And if trying to rule out the differential diagnosis, which would include a stress fracture, MRI may be useful as well. But most typically, this is a clinical diagnosis not requiring any investigations. Treatment involves symptomatic relief, including rest, ice, analgesia, and switching to a pain-free form of cross-training, taping or custom orthotics with a semi-rigid medial arch support for those with hyperpronated feet, and offering shock absorption is often therapeutic. Considering a knee-high pneumatic splint or an air cast walking boot in the initial phase, if there is pain with activities of daily living, may expedite recovery, and often is necessary in those initial phases when trying to distinguish between severe medial tibial stress syndrome or stress fracture. Low quality data exists for prolotherapy and PRP injections, and in resistant cases, rarely surgical release may be considered.